Yeah.
So thank you so much, Dr. Shruti, for your nice introduction. So I'll be sharing my screen. First of all, I would like to thank Dr. Shruti for inviting me to this introduction instruction course. And also thankful to for AIOS Scientific Committee for accepting this instruction course. So I'm Dr. Prashant. I'll be talking about the clinical evaluation of optic nerve head in different conditions. So first of all, I have no financial interest. Am I audible, Shruti?
Yes, you are.
So first of all, I have no financial interest in any of the equipments, instruments, or the procedure which is shown in my presentation. So when we are going to evaluate the disc, the first thing we have to consider that it is always better to evaluate a disc in a two-dimensional, three-dimensional way. So stereoscopically, we have to use different lenses, a 90 diopter or 60 diopter lens or a 70 diopter lens, sit on slit lamp and examine the patient on slit lamp so that we get to see all the details of the optic disc. Sometimes when we examine the patient with a direct ophthalmoscope, we tend to miss certain findings, and certain findings when we miss, so we can miss a diagnosis of any disease. So optic disc is, what is optic disc? It's a visual part of optic nerve head which connects eyes to the brain, and the boundary of the optic disc is defined by the scleral canal. So in hypermetropes, the size of the scleral canal is smaller, whereas in myopes, the size of the canal is bigger. That is why the size of the optic disc varies from person to person. So normally it varies from 0.96 millimeter to 2.9 millimeter in different people. So a small disc and large disc, there are different variations we've seen. As a result, the physiological cup can also be small as 0.1 and can be as large as 0.8. So it is essential to first measure the size of the disc for a proper evaluation of optic nerve head. So how do we measure the size of the disc? So if you put if the patient is sitting on a slit lamp, we just put a thin beam of slit, and we can put it across the margin of the disc, which is margin of the scleral canal. So this is the margin of the disc, and we measure the size of this beam with the graticule which is present over the slit lamp in the upper portion of the slit lamp. And whatever is the reading, we have to correct it with the magnification factor. Now, different lenses, since they are magnifier, different lenses have different magnification factor. So if you're using a 60 diopter lens, it is 1, which is similar to the size. If you're using a 78 diopter lens, it is 1.1 times. You have to multiply 1.1 times. If you're using a 90 diopter lens, so you have to multiply 1.3 times. That will give you an idea of actual size of the disc. Why correlation of size is so important? Because there are certain conditions which are present in small disc which mimics different conditions. So there can be confusion because of the size of the disc. Few of the conditions are optic nerve head Duchenne's, non-arteritic anterior ischemic neuropathy, and pseudopapillary edema. Now, this is a picture of a Duchenne. Duchenne's are generally Duchenne's are collection of proteins and calcium in the optic nerve head, which gives the disc appearance of gives a little bumpy appearance. The disc will, if the Duchenne is present on the surface, it will appear like elevated disc and also a bumpy disc, and also the margins becomes indistinct. So it will mimic a condition called as papilledema. Now, papilledema is a condition in which there is high intracranial tension, and that is a high intracranial tension. That is a medical emergency that may require urgent lumbar puncture. So we have to be sure what is Duchenne and what is papilledema. A large disc, there are conditions which are present in large disc, like morning glory syndrome, which is the central excavation of the disc, which is because of premature closing of embryonic fissure, and congenital optic nerve pit. So these are the conditions which are present in the large disc. So after studying the size of the disc, next is shape of the disc. So shape of the disc normally can be vertically oval, is vertically oval. And the cup is horizontally oval. So if you see the disc, the shape is vertically oval and the cup is horizontally oval. If the cup becomes vertically oval, that means there is loss of neuroretinal rim over here and here. So generally in glaucoma, the first area to be affected is vertical, superior neuroretinal rim, inferior retinal rim. So the cup becomes vertical. So enlargement of the cup as well as shape of the cup is very suspicious of glaucoma and other diseases. Next point to note is the color of the optic disc. Now, color is very important in evaluation of optic nerve head, because color will give you a guide of different diseases. If you see a pallor like this in optic disc, which is very significant, so you should think of pathology which is other than glaucoma. Apart from cupping, you have to see the pallor. So you have to think of pathology other than glaucoma. And according to Greenfield criteria, if you have a pallor, significant pallor along with significant drop in vision, you must do neurological imaging to rule out other causes of this pallor. So this is the disc picture which shows sectoral pallor here, and this area. So this is suggestive of a non-arthritic anti-ischemic neuropathy, and we must do neurological imaging in these such cases. Next area is optic cup. So the central pale area is called as optic cup. The central pale area is called optic cup. The central pale area is optic cup. This area doesn't have any axon, but they have glial tissue. It becomes more pale when there is enlarged cupping of the disc because exposure to the underlying collagen fibers. When we are determining size of the cup, we have to see the contour of the vessel, not the actual size of the pallor. So generally, we have a tendency to see the area of paleness, but we have to see the area of the bending of the vessels. So in this picture, so generally we see the we feel that the cupping is from here to here, but actually we have to see this is the area of pale. This is the pale area, not the cup area. So actual cup area is determined by the area where vessels are actually bending. So we have to draw a contour line, which actually determined by bending of vessels. Like in this picture, we see the pallor is going beyond the area of cupping. So drawing a contour line which actually determines and will be helpful to determine the actual area of the cupping. Next area of interest, and in fact, it is the area of most interest in the evaluation of many diseases, is the neuroretinal rim. It is a pink-orange area, which is in between the margin of optic disc and the cup. As I said, the cup should be determined by the margin, the bending of the vessels. So this is the area which is important to us and which should be interesting to us, not the central cup. As in this donut, we are not interested in the central hole, we are interested in this chocolate. And similarly, in the disc, we have to evaluate the rim, not the cup. So normally the disc follows IS-N2 rule, which says that the inferior rim is generally thicker as compared to the superior, and then nasal, and the temporal is the thinner most area of the disc. The similar rule is followed. So most of the disc follow this IS-N2 rule. Some of the disc will not follow, and if there is no, if the disc is not following IS-N2 rule, we must think that there is some pathology in the eye. That could be glaucoma or something else. Like this, both the discs are. We can see both the pictures. The discs are very big, large disc, but these discs are following the IS-N2 rule. So inferior rim is thicker. So these can be a normal disc. Next point to note is asymmetry between two eyes, asymmetry of disc in between two eyes. So we have to look at the size of the disc, width of the neuroretinal rim, vessel course, and parapapillary atrophy. And if the cup size ratio, so normally 0.2 is a normal asymmetry which can be present in 96% of the patients, but if the different in asymmetry is more than 0.2, that could raise a suspicion of glaucoma. So more than 0.2 asymmetry, one should do for further follow-up and investigation to rule out glaucoma. Next area to study is retinal and nerve fiber layer. So nerve fiber layer are best visualized through dilated pupil, and they appear as white striations over the beyond the margin of the disc, and mostly they are visible in superior and inferior area because the nerve fiber layer is thicker at those areas. It is best appreciated by green light or red free filter. So pattern of nerve fiber loss can be slit, wedge, or diffuse. So in this picture, we see there is inferior thinning of the disc along with a wedge-shaped defect. The wedge-shaped defect of the nerve fiber layer, which is highly suspicious of glaucoma. In the red free image, we can see the defect is more clear here, which appears as a darker area. In this picture, in the disc fundus diagram, you can see diffuse area of RNFL defects. So multiple RNFL defects are present. So there is diffuse RNFL defect, which is also suggestive of glaucoma. If there is an RNFL defect, wedge-shaped RNFL defect, which is present in temporal, not in this picture, but if you find a defect which is temporal, that indicates an oblique insertion of optic disc, because temporal area you don't get normally a defect, wedge-shaped defect. So here we can see the normally diffuse RNFL defect. Again, in this picture. Next area is parapapillary atrophy or peripapillary atrophy. So these are thinning and atrophy and degeneration of chorioretinal tissue because of ischemia and poor blood supply. that exposes an underlying retinal pigmented epithelium, which gives tissue a moth-eaten appearance. So PPA differs, perivalvular atrophy differs from normal choroidal crescent that we find in myopia, and also inferior scleral crescent that we find in tilted optic disc. Now it has two zones. One, the peripheral zone is called zone alpha. The central zone is called zone beta. The peripheral zone is a peripheral crescent is characterized by irregularities of RPE because of atrophy of choriocapillaries. So they appear as a dark area here. Whereas zone beta is a complete absence of choriocapillary and RPE. So underlying sclera is visible here and choroid visible here. So that appears a more darker area, and it is more significant in case of glaucoma. And there are various studies where it's documented that zone beta is more prominent in cases of ocular hypertensive and normal tension glaucoma. Next finding is to examine the optic nerve head for to find any hemorrhage. So these hemorrhages are called Drans hemorrhage, which are present at the margin of the disc or one disc diameter away from the disc. It is basically occurs because of infarct of retinal nerve fiber layer, and it is mostly involved. If you find a hemorrhage like this, it could be a case of normal tension glaucoma or primary open angle glaucoma, which is progressing. In this two landmark trial in the glaucoma, early manifest glaucoma trial and collaborative normal tension glaucoma trial, they have documented that presence of nerve hemorrhage or Drans hemorrhage is highly suggestive of optic nerve progression, optic nerve glaucoma progression. Although they can also be present in NAIO and hypertensive and diabetic retinopathy. And at last, I would like to tell there are other certain subtle signs in glaucoma which is present in optic disc. These are not pathognomonic of glaucoma, but they are also present in glaucoma. So that again increases the evidence or to diagnose a case of glaucoma. They are laminar dot sign and bean pot cupping. Now, laminar dot sign is presence of prominent laminar dots because of thinning, excessive cupping of the upper disc. And bean pot cupping and venotic sign is because of excessive excavation of the cup, the bending of vessel, because bending of blood vessel and excessive excavation of cup, it appears. And also because of loss of neoretinal rim, there may be nasalization of blood vessel and bearing of circumlinear vessels. So these are soft signs of glaucoma, which is not pathognomonic. So best is to examine the disc and examine the neural. This is my summary. So assessment of disc size and disc color is very important in evaluation of optic nerve head for any of the disease. Cupping of the disc should not be decided by the color or pale area. It should be decided by the contour. Single evaluation of optic disc head is not sufficient, and also evaluation of CDR is not sufficient because observation may vary from person to person. And so for serial follow-up of a patient, optic disc photograph is the best tool to document and follow up. Thank you so much for your patient hearing.